Good afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We are delighted that you're able to join us virtually today for the second webinar in our new virtual webinar series. The Trust is pleased to be able to offer this type of informative content free of charge to our policyholders. Make sure you block time in your schedule for our next Risk Management Roundtable being held on Thursday, April the 30th at 5 p.m. Eastern Time, and our next Telehealth Community Chat on Monday, May 11th at 5 p.m. Eastern Time. I also want to remind you of the COVID-19 resources page we've put together, where you'll find resources created by the Trust and our partners. We'll continue to post updated content as it becomes available. You can find a link to this page, as well as the virtual webinar series page, on the important information slide. Here at the Trust, we live by our motto, for psychologists, by psychologists. It resonates in everything we do, and we pride ourselves on being able to support the profession of psychology in ways that no one else can. The Trust is pleased to partner with Drs. Margot Adams-Larson and Sarah Smucker-Barnwell to present these telehealth community chats. Dr. Larson's expertise targets the development of technology in practice and the regulatory considerations of this growing method of service delivery, while Dr. Barnwell's experience focuses on the intersection of technology and behavioral health. In the interest of time, we've placed their bios on a slide for you. Before they begin the presentation, I have a few additional things to tell you. First, we hope this will go just as smoothly as our previous live stream webinars, but should there be a technical problem, please bear with us. We'll do our best to keep things moving. If you do happen to run into any issues that you're unable to resolve after using the instructions provided at registration, contact our Customer Service Center at 800-477-1200 or send an email to seminars@trustinsurance.com. Because our time is limited to an hour and we have so much great content to cover, we made the decision for this not to be interactive today and have therefore disabled the chat functionality. However, you'll notice the Q&A feature is active. This is where you can submit questions to be considered for future use, or you can email them to telehealthcommunity@trustinsurance.com. This virtual webinar will earn you 1 CE credit. This can be combined with other risk management credits to save up to 15% on your Trust-sponsored professional liability insurance policy. Please remember to submit your CE certificates with your policy renewal. At the end of the webinar, you will be provided with a link in the chat box, which will link you to your exam and certificate upon completion. Again, I hope everyone learns a lot over the next hour. Please join me in welcoming our esteemed presenters.
Thank you so much, Jana, and thank you to the Trust for hosting these telehealth community chats. It is my pleasure to be here today with Margot Adams-Larson to be talking about themes related to telehealth and its practice during this really unprecedented period of time in psychologist practice. I'm Sarah Smucker-Barnwell. I'm a clinical psychologist licensed in Washington State. And as Dr. Martin noted, it is really my passion to talk about themes of how we can bring sound behavioral health practices to diverse populations through the use of technology in ethical and risk-managed ways.
Hi, Sarah. I'm so glad to be here, and thank you so much, Dr. Martin, for that great introduction. Super thrilled to be chatting today about the changes that we're all pivoting to in telepractice and telepsychology especially. I am a licensed psychologist in North Dakota, and I actually have been working remotely for several years for a technology company, Virtually Better, in Atlanta, Georgia. So I'm familiar with the virtual video conferencing platform. I have a small practice in North Dakota and have pivoted very recently to virtual and video conferencing with all of our patients as well. So I'm thrilled to chat more. And Sarah, you know, as all of this COVID was happening, you were the first person that came to my mind to be able to call up and touch base and just kind of consult on what all is going on and what you're finding happening in your practice. So I'm glad that we could review again together some of the things that we've been chatting about. So we do have a few disclosures, and I'll let you kick off a little bit with that.
Sure. Well, you know, I think both Margot and I participate in the world of telehealth training. And we always like to disclose that, you know, you might say we have a horse in the race of telehealth, but this is because we really are both passionate believers in the impact of this modality, and particularly at this moment in history, the opportunity for telehealth to help protect our health, the health of our clients, and the public health. So we really are both sort of telehealth enthusiasts, perhaps even telehealth evangelists. You know, so here in this moment, I'm really just excited, Margot, to be able to touch base, because you really are my first person go-to consultation resource. As we always say, you know, whenever you and I have done talks in the past on telehealth, if you're giving a presentation on technology, something surely will go wrong with your technology. So we just offer that in our disclosure to just really, with a Nostradamus-like prediction, anticipate that something will go awry. But knock on wood, hopefully we said it aloud so it won't.
Well, and with that caveat, we'll be talking a lot about technology today, and perhaps some hacks and tips and tricks that we've learned along the way to pass along to those of you watching about how you can learn from some of the things that have gone wrong in the past to really guard against and really be thinking through your clinical practice as you're embarking upon bringing a lot of technology into it. Our idea with these telehealth community chats is really to have kind of a bi-monthly check-in, see how things are changing and pivoting, anticipating that we've all kind of come through the last month and a half, 2 months of really ramping up a kind of almost a really new way of seeing our work worlds. And realizing that that's going to unwind somehow, hopefully in the near future, but as it is, we may not be unwinding back to what it used to be, and a lot of things that we need to still be keeping in mind and thinking ahead as we go forward with both practicing regular psychology as well as telepsychology. So we'll talk about practice guidelines, clinical concerns, ethical considerations, and some of the regulatory environment. Our goal is not to replace your consultations with risk managers by any stretch, but really to share in some of those conversations and help you feel more comfortable with the clinical and ethical aspects that are cropping up, and concerns and considerations that are coming along. Both Sarah and I have had a lot of questions from colleagues, local and far, and we'd love to hear your questions too. So we have the telehealth community at trustinsurance.com, where you can find that on all the slides, but that's where you can send in your email questions. Again, we're not taking those live today, but we will be using those to populate moving forward for our next chat. So just keeping that in mind. We do have a ton of agenda items for today because there have been so many questions, and kind of as a guide, we thought we would pull from some of those questions and some of the top ideas and things that we've really been answering in the past couple months, and put those together for our conversation and chat today.
So Margot, as we get started, we wanted to mention here are all the themes that we're going to talk about, and we'll try to kind of break them down into several sub-themes. We'll try to get to all of them. That's our goal for the day. But again, If there are themes that are not discussed here that you'd like to hear about in the future, please use that email at the bottom of the screen and let us know what's on your mind. We like to think a little bit, starting off, about video conferencing platforms. I don't know about you, Margot, this is probably the question I get the most from people. What video conferencing platform should I use? And
it's a big one.
It's a big one, and it's changed. If somebody asked me that question 6 months ago, it's a very different environment than what we are living in today. In the past several months, there was an announcement from the Office of Civil Rights and the U.S. Department of Health and Human Services relaxing some of the requirements for HIPAA on video conferencing and allowing us to use products that are non-public facing. And so by that, we mean your Skypes, your FaceTimes, your Zooms, products like this. They're not talking about FaceTime Live, they're not talking about Instagram TV, they're not promoting putting our therapy sessions on a live channel to be viewed by others. But they are saying using those those video conferencing products that are used in our social lives, more popularly perhaps in our other professional lives, for consultation with colleagues and so forth. So it's a really different series of recommendations. And I think, Margot, one of the things you and I have talked about that's really tricky is that we could make a recommendation today and say, today, this is absolutely the best platform, you should use it. And 2 weeks from now, we'll be wrong because
the rules will change.
It moves fast. And so, I think we're going to offer some specific recommendations today, but we're also going to try to focus on guidelines, really helping folks think through how to pick a product that's best suited for them. I know one of the themes you and I always talk about, Margot, is whether to use a product designed for healthcare versus not. And, I really have an opinion on this one. I really come down on the side of using that product designed for healthcare. When we use a product that's designed for healthcare, I think we are entering into a compact with a company that is just aware of our concerns, our considerations. Often they will offer us a business associates agreement, or BAA. And that's a document that says, hey, I'm going to be your partner in, complying with HIPAA, complying with high tech, complying with some of these federal regulations, specifically complying with HIPAA. And that agreement will require them to do things like let us know if there's a security breach, or will require them not to participate in certain quality management practices that would not be in compliance with HIPAA. I know we talked about Skype, for example. It's a great product. A lot of people use it. We now can use it according to the Office of Civil Rights and DHHS. But it also has a practice wherein when they're checking on call quality, they have folks actually watch snippets of calls. I don't think they're trying to steal our sweet therapy secrets, but I think they are checking on things like lag with the voice. They're checking on pixelation of the image. They're checking in on these things in ways that are not conducive to a HIPAA compliant product. So, my general feeling is we are better off when we can to use a product designed for medical purposes. I like to use, among the paid products, I use Simple Practice, which is an electronic medical record. It has an integrated video component. That being said, there are many excellent ones. Therapy Notes, Theranest, Therapy Appointment. There are a lot of great different providers that offer the service. There's a great free product that I really like called Doxy.me, which is a nice sort of standalone. It's just a video conferencing treatment room and waiting room. It works really well. It's very simple, very user-friendly, and it's free. So for people who are just adding a video conferencing platform now, maybe they don't have it integrated into their electronic medical record, or maybe they've never used an electronic medical record, it's a nice product that they can hop on, use in a very sort of adjunct way and help, bring telehealth into their practice.
I think that's a really important point. When there is, typically the BAAs have meant you have to pay extra or pay for the service, right? And I think that was probably part of the relaxing of some of those, from the federal level of some of those HIPAA requirements. But we do have options that are free, that don't break the bank, that can help you connect with patients, in a way that still complies with those requirements. And I think that comes down to what you were saying. Whenever you can do that, you might as well. And in this case, it's a free way of doing that.
Right.
So, I certainly agree with you on that point.
And I think you get, a thing I observe is on the paid products, you tend to get a few more bells and whistles. Although I will mention, and this is the one time I will like come down not on the side of healthcare products. Non-healthcare products have fancier options because when you're not thinking about HIPAA, when you're not thinking about security as your first and foremost consideration, you're more likely to facilitate things like screen sharing, like having multiple callers join in on a call, like having snazzy backgrounds, you know. You get more features often with those non-public facing products. But I will say among the healthcare products, the free versus the paid products are very often, again, they're often integrated in ways with other services that anticipate our needs. So they may help us do things like secure document transfer. So if I need to figure out a way to get an informed consent document, to get an emergency plan, to get some sort of documentation, homework back and forth with my client, sometimes these paid products designed for healthcare will have integrated options that facilitate some of the other things I may need to do. Signatures are a great example, the ability to capture the signature of a client. Now, of course, we can purchase supplemental technologies, you know, there's technologies like DocuSign or Carbonite or, you know, other ways in which we can store and share information. But again, if it's one-stop shopping, it's kind of nice.
Well, we had talked about this before on our update, and that I really had a strong feeling about, you know, is this the time that people should leap into an electronic medical record? And I know we're talking about video conferencing, but it does come up because people are, you know, looking for the video conferencing. Should they buy the whole thing or buy into the whole thing? And as stressful as the past few months have been, if you haven't already had an electronic medical record, it's probably not really the time that you want to add that extra bonus fun of changing over all of your records into an electronic medical record. So that may be something, while it sounds great, that you're looking for video conferencing and it's all integrated. If that's not what you've been doing already, it's probably not the moment that you might want to.
Right.
Or maybe said another way, you want to think about that if you really want to have an additional fun holiday.
Well, you know, we talked about it's not even the video piece. It's the video piece will be very simple. That will be the least of your troubles. It is when you transition over to an electronic medical record from not having used one previously. In all likelihood, you will now be submitting your insurance claims. If you bill insurance differently, you'll be managing the collection of payment and the tracking of payments differently. And this will look a bit different. And so it's a big investment of time and sort of mental energy during a period of time where we might find these things in short supply.
Right. And maybe we'll add that to our list for the next chat if folks are interested in that one. But
you just run out of patience.
You know, I'm glad that you mentioned kind of the variety of products, and we'll have a resource slide at the end of this presentation. So if folks are not writing down now, they can catch up with that. But, you know, one of the document transfers you had mentioned too was just kind of this idea of, you know, how to make that flow through HIPAA compliant platforms. And maybe that's another topic too that we want to just think about for a future chat of how we might address that for folks too.
Absolutely. I mean, I think this is all going to be a part of a larger system of practice. And for many of us, there's sort of this outstanding question of how long will telehealth be a mainstay of our practice? And I think our investment of time and resources and products sort of needs to align with that. So if I say, you know what, meaningfully, I think I'm going to be doing this for over a year, I'm probably going to be investing more in streamlined solutions about how to solve these sort of everyday problems of practice, versus if I'm just counting down the days, you know, until my stay home order ends and I know I will be back to business more as usual.
You have
acknowledging this is an unknown for many of us.
Do you have a countdown going?
I don't. I mean, no, I love some telehealth. So, but I know some colleagues who do, and so I guess I want to acknowledge and respect there are different ways to be treating this theme, and I don't seek to diminish or marginalize this.
Well, maybe that's a great segue into just some video conferencing etiquette. And this has come up as a lot of us have finished probably week 2 or 3 of both patient-related video conferencing, as well as just regular interactions with our office colleagues, whether that's consulting with them or office staff, that we're now doing video conferencing in that way. I know a lot of offices have been actually transitioning to some video conferencing just to kind of have check-ins and see how everyone's doing. So I think it's really important to cover a little bit of video conferencing etiquette as some of these things have come up. Logging in early, because as we mentioned way at the beginning, technology is bound to fail often in the first, attempts to actually log into the meeting. And sometimes once you get in, you might get bumped out. So making sure that your connection is stable and running smoothly, it really, spend a little extra time on the front end, 5 minutes before a call to be on early. Making sure the devices that you're using are plugged in. Video conferencing takes a lot of bandwidth on internet, but it also takes a lot of demand out of your devices. And you will find, phones and iPads, they just run down a whole lot faster with the video conference streaming. So making sure everything's plugged in. You had mentioned some of the fancy bells and whistles that happen with Zoom, not the Zoom bombers, but just the Zoom abilities. And while they're great, they do take a lot of bandwidth out of your transmissions. And so that can lead to the audio being more jittery. You really want to try and limit what's in the background. Sarah's background's a great example of kind of very, non-distracting, easy to contrast with you as the person kind of in the video.
I've told you it's the most boring section of wall in my house. It's not the most beautiful, but there's no pictures of my family. There's no interesting art. It's just wall and closet door, and that's it.
I think also as you're logging into video calls, making sure you're muted if you're not the host, and that you unmute yourself when it is time for you to speak. There's a lot of people hopping on and they're still having other conversations. Make sure you're using a professional name in the naming feature. Happened to be on a call last week, I kid you not, and somebody joined the professional meeting and their name was Boobs. Fortunately, they quickly realized this, but you can't always predict what Zoom is going to bring over to your next meeting, and you sure don't want that to be what you're showing up to see your clients with.
I really want to know what their prior call was about.
I know, it's maybe that was one of those fun legal consultations. I don't know. One of the other features that you do want to think about as you're setting up for video conferencing is having enough lighting on your face. And this is a real tricky one because you may, in a regular office setting or home office setting, feel like you have a large, well-lit space. But oftentimes, if you have a window behind you or beside you, or the sun's not coming in, you can really appear as though you're, very dark in the face, or you can't see the facial expressions. You don't want to appear in the witness protection program unless you're Boobs, in which case maybe that is the way to show up for the meeting.
I really agree. It's having adequate light on our faces, I think, helps clinical rapport because it helps pick up some of those more minute facial expressions, some of those little, just small tells that I think help increase engagement and help the client really feel like they're having a more emotional interaction, versus when we're a little bit more obscured and shaded and they can't really see us as well.
I totally agree. And, making sure that you are seen and can be heard when you're working with clients. And that really is kind of the first check-in of the call. And helping your clients and patients understand these same principles too is really good. So making sure they're not logging in kind of the context of, maybe not the best or most professional office kind of space. And we'll talk about some of the challenges with that as we go through some of our next items as well. But really trying to find a space that seems professional, or you can create it to be professional and private and conveys that to whoever you're having the video conferencing with is key.
I think it's a nice example and nice modeling for our clients to help them sort of understand the benchmark expectation regarding, what they need to be doing on their end as well. If I met them in my pajamas in my bed, it doesn't comport, I'm not comporting myself well professionally. It's not a very nice image, but also I'm suggesting to them that this is a less boundaried and more casual interaction than the one I would likely want to have with them. I appreciate your talking about making sure you are heard and seen, because over the last few weeks, I have probably 2 or 3 times I've entered a video call, someone was in the waiting room, I'm connected, I'm speaking to them, and they appear to be looking at me and nodding slightly. And I think we're just having a very unusual, but having an interaction. We're having a strange greeting. And then I quickly realized they actually have their computer open to other tabs, and they're typing away, and they are just not even aware that I'm there. They've muted, the computer. And so, making sure that we're having the interaction we think we're having, which segues nicely into talking about intakes.
It does. And maybe you can tell us a little bit more about some of those experiences, and both with maybe the existing patients that you have been seeing and maybe kind of some of those differences.
Yes, I think it's a really good point, because in those initial weeks, I've been in this house a long time, Margot. I've been in here since the end of February. And in those initial weeks, I was mostly just transitioning my existing clients. And I think that's a very different task. Mm-hmm. Yes, I want an informed consent telehealth, and I want to document an emergency plan, but otherwise I've established care with them. I'll acknowledge that the treatment plans have changed. I do a lot of exposure therapy. I do a lot of in vivo. We're just trying to make it work. But, our concerns are different. Our treatment, plans may be different, but fundamentally I have rapport. I know these folks and I've worked with them. So I think that work is different work than onboarding a new client. And I think that honestly, I feel like I have a little bit more benefit of the doubt and a little bit more capital to spend, when thinking about the relationship I have with these existing clients. We can kind of go through this experience of transition together in a way that can lean into our existing clinical relationship. But when I'm, onboarding a new client, it's a different cup of tea.
Right.
So I think, first of all, just thinking about where those clients come from. I know I have a website for my practice. I advertise, on some of the national referral database services. I have Psychology Today is one that I participate in. There's also, places like the National Register, our state psych association, American Psychological Association, all have great databases that you can go and you can access a local therapist. So, I think I'm getting some referrals in through those sources. I know I have been proactive in reaching out to some of my primary care, my community primary care clinics and specialty care clinics, just reminding them, hey, myself and my colleagues in my practice are accepting new clients. We're seeing folks over telehealth. We're able to deliver care in a socially distanced way. And I think they appreciated those contacts. They said, oh, thanks, we'll send referrals your way. And lo and behold, we have seen referrals coming from those places. So first you got to find them. Once you find them, thinking a little bit about how you get set up. I know I like to, really even before we set up anything, and this is for my in-person clients as well, I like to have a brief phone call. Now I know some folks do it differently. They'd prefer to go through their electronic medical record and collect information that way. And that's their first point of contact. They'll email with folks. That can be a first point of contact. If you have a secure email that's HIPAA compliant, all the better. Though acknowledging that, again, OCR and DHHS has relaxed some of these requirements. But I like to have a phone call. I like to check in, make sure that I think this person is best suited by my practice and not a colleague's practice who has a different specialty than mine. I just fundamentally want to get a sense of what's going on and make sure that I think I'm a competent provider for the case. From there, I usually do my scheduling. And so these are pretty low-tech ways. I could use my EMR. It does have that functionality and that capacity, but I choose to do it a little bit more old-fashioned. For folks who have never used video conferencing previously, and I've had a few clients I brought on through new intakes that is the case, I like to establish a 5-minute video conferencing call so they can try it out. I want them to be
a great idea.
So, right, so they can kind of see what it's like, they can get a sense. I can see what's going on in their environment. Now, the question has been raised with me whether or not to get the informed consent before or after that.
Mm.
I am in favor of before, reasonable minds, I suppose, but I would say before. And again, how are we getting it? It can be a very low-tech solution. I can send it through the mail, they can send it back. I can fax it to them, they can fax it back. They can download it off my website, carrier pigeon. I don't know. Don't carry pigeon.
That might be what we're resorting to soon, though.
I go there.
Drone.
Make it into an airplane. No, don't do that.
When we had chatted just briefly about this before, you have mentioned that some practices were actually using video conferencing with kind of the intake staff or reception staff in that same kind of manner. So actually, instead of telephone or in addition to telephone, they were now doing that. And that was really intriguing to me. Would you get the consent for video conferencing then if it's your office receptionist participating in that?
It's an option. I don't know that I would do the consent there. I would say that I have seen a few practices using frontline staff they're really checking on the lighting, they're making sure the door is closed, they're making sure the client is center of screen, and they're maybe collecting information like PHQ or GAD7, PHQ 9 and GAD7, yes. I think that for the informed consent, it's my opinion that it's nice for the provider to go over that with the client. And again, the highest standard, the standard we really want, is the actual document with the signature that they have through non-carrier pigeon means gotten to us. However, as the wonderful risk managers at the most recent roundtable 2 weeks ago, or a week and a half ago, indicated, it is possible to obtain that via verbal consent. So I could imagine, reviewing that verbally and documenting that you had the conversation at the chart is also a good option if you just can't get it any other way. And as always, we're sort of doing our best, we're being reasonable, we're making efforts, and we're documenting those efforts. So once that client gets into that 5-minute call, we figure out this is going to work well for them, and we go decide we're going to have our proper intake and schedule that. Hopefully in advance, we have figured out themes like how to get that emergency plan document, how to get that informed consent. If not, we're going over it verbally in the intake and we're documenting that conversation. I think that from there, we're just really trying to slow it down, focus on clinical engagement, because again, there are a lot of things you're not going to see and you're just not going to catch. We're going to talk about that in our hacks section, but there's some behavioral observation data that we're just not going to get. So I think there's this opportunity to be really transparent about that process, slow down. I try to collect a lot of information through questionnaires in advance, so I have that available, and just kind of do my best and go from there.
Well, that kind of segues nicely to our next topic. We didn't plan this out or anything, but and that is assessment. A lot of our colleagues are in the world of neuropsych assessment or forensic assessment or even school assessments. And at this point, we've had a really big pivot for the assessment world. And even for those who were kind of in the process of completing batteries, I think there's been a lot of questions raised about, is this even something we can do from a video conferencing standpoint? How might we pivot? From a neuropsychological standpoint, we've got so many different factors to consider. The nature of kind of what the referral or the assessment questions were to begin with, the age of the participant that we're evaluating, the types of assessment tools we were selecting for that or planning for that, and how we might pivot or change, or if it's even the same. And then, for a lot of the considerations, both the change globally that we're all experiencing, and whether or not the assessment would actually be the same assessment as what they were referred for, or impacted by that change at the moment, and all of the aspects of norms and security and validity of how we might administer an assessment in video conferencing. So in the past couple weeks, I saw a fantastic APA resource tool. We'll have a link for that in our resource slide at the end. But specifically talking about, just some of these factors, and also billing related factors of if you are going ahead with assessment, how that might be coded or billed appropriately. So maybe we could pivot a little bit and just kind of talk about some of the things we've chatted on related to assessments and some of the biggest challenges that we've thought about.
I mean, I really appreciate your question, Margot, which is, has the referral question changed, or how can it be applied, in circumstances, for example, for forensic cases, when the courts are closed, it's hard to think about, how we're moving forward with this, or even in educational assessments. Are we going to do a Zoom classroom observation? How do we think about the referral? Right, Zoom bomb. That's what those Zoom bombers are doing, clearly. Right. And I think the thing, you and I have talked a lot about is ultimately we may end up with changed batteries. I watched a great webinar through the Trust that talked about an observed MMPI administration. And it really got me thinking about, are there measures that can be observed, acknowledging, I don't know the impacts on the norms, and it's like, there are times at which, for example, this is a very, not necessarily sensitive or specific application, but I like collecting a PHQ-9 before clients come in. It's just a habit. I've done it forever. And now I might do it verbally. I am certain my reading that aloud changes things. I am certain that verbal interaction, I can't be certain, I've never empirically tested it, but I do think. So I think, we're really looking at different ways of doing the batteries. Are we observing people doing it? Are we verbally reading people to do it? As you said, we need to think about, are we allowed to do that? Is the tests permissions aligned with doing that? How does that impact the norms? And I think for a lot of folks, they're just having changed batteries. They're having more abbreviated batteries. There are some tests, there's just not a good way of doing them remotely. I acknowledge that, Pearson and a lot of the other companies are doing great jobs, great efforts to bring some of these tools online for us quickly and in ways that are ethical and academically sort of oriented. But there's just a practical reality that it may or may not work well. And so there's kind of this, we run into a barrier that some batteries will need to be changed and perhaps abbreviated.
And you do raise kind of that ethical conundrum that I have always thought about with technology in general. Across the board, all professions, technology brings us these fantastic tools. But just because we can, doesn't really mean we should, right? And there's lots of ways we could think around how to solve for some of these things. But again, we want to really answer that question of, even if we can, should we move forward with some of these services? And that being true also for some of just the regular clinical applications. But I think especially in assessment, there has been no better time to really hone our clinical interview skills as now. And that's kind of one of those things we're going to chat about with the hacks section. But this idea of, we're missing a lot of information in the video that behaviorally we would observe in person, as are our patients, by the way. They're not getting that same kind of reading and feedback that we have in our body language. So, but in particular, we can't know what's behind the camera. We can see a large part of what's in front of the camera, but what and who and everything going on behind the camera, you don't know. I'm looking out my lovely windows in my beautiful backyard and watching the neighbors' dogs race all over while I'm chatting with you. They're not impacting my assessment, but you do have to think about that as a provider, trying to come up with workarounds for these assessment scenarios.
we really can't assume. And I think, one of the assessment environments that feels really pronounced for me is with kids.
Mm.
It just seems that folks are having to really approach like those clinical interviewing skills differently. I know some folks are talking about, initially some folks were saying they were, using some of the screen and some of the features and, like some of the more fun features of the video conferencing to liven it up, with the young ones. I think now people are describing Zoom fatigue, that the kids are coming after online school and they're just feeling over it. Some people are talking about having to have breaks because of some of that fatigue and because of some of just the nature of, one more screen for the kiddo. They're abbreviating those assessments. I know one colleague, instead of doing a 90-minute assessment, which is their standard 90791 intake, excuse me, that's not an assessment case, that would be a therapy intake. They are doing hour-long, sessions, because they said going longer, at least with the age cohort that they work with younger children, it was just too much. And I think people are having to be really inventive. I know a lot of folks are talking about parental involvement, getting the parents more sort of actively involved, whereas normally they would have the parents lead for greater parts of the session, having the parents kind of there to help kind of keep things, on the rails, which again, I want to acknowledge that's going to impact some of our outcomes. And I think that's something we just sort of need to embrace in this current environment, because it is going to be different.
And I like that you're saying it will be different. Doesn't mean that it's worse. It may in fact be better, causing us to actually shrink and focus, the time to the child's focus and concentration. But if that's what we're assessing, or that was the goal of the assessment, I think we have a whole new ballpark that we're really trying to kind of fit some old tools for, and that might not be meeting all the needs that are happening at the moment because of that overwhelm and Zoom all day and all of those kinds of things. Given our time, I'd like to head over into some of the hacks. We've mentioned a few of these. I think some of the biggest ones are really just kind of back thinking about the behavioral, observational, even the eye contact and connection. We want to make sure, like I said, that we can see your face, but even at that, we want to be focusing a little bit and actually verbalizing and talking about the eye gaze, because if we're making a note, and I'm going to overemphasize this because I think probably the viewers are going to see us in a pretty small screen, but if I'm making notes, I may be facing down and my gaze on the camera is right here when I'm looking at the camera, but I can't see you, Sarah, when I'm looking at the camera because your video feed is over here. And so we do want to kind of talk with clients about that, give them tips and hints as well. And we may want to overemphasize as well some of our emotive body language expressions. And I know a number of colleagues have complained that this is exhausting, right? It's just like, oh my gosh, it's a whole lot of work. And I think that's both ramping up and getting used to all the video and everything else that you have to keep track of. But in order to convey, it's kind of like they used to joke about, when you go on camera, you gain 10 pounds. Well, it's like camera takes away your emotive abilities as well. And so if you want that to show up, you really have to overemphasize that. And it's downright training by the end of the week.
And particularly for those of us who are hand talkers, like I am just an unabashed hand talker, and it is so hard for me because it can be helpful in some moments and it can be distracting in others. So there's some moments I literally, Margot, will sit with a pen and hold on both sides to control myself, to prevent myself from gesticulating wildly. Because again, the more I move, and I'm not going to do this on our call today because I don't want to freeze anyone, but if I were to wave my hands around vigorously, I'm creating more demand on the bandwidth of the call, and I'm actually creating a circumstance in which it's more likely to freeze. So I want to show up in my face, I want to show up in my body postures, but I want to keep my jazz hands to a minimum.
And if you can back up off the camera, but also still show up, I mean, it's just, there is a lot of subtle things to keep in mind with this video conferencing, and as you're transitioning to it. And then when you transition back to in person, you're going to have to keep that in mind as well, because you don't want to become overly exuberant
Right.
unintentionally in person. So those are some things to think about. The other hacks I wanted to make sure that we mention is our backups.
Yeah.
Meaning, if something goes wrong, if the Wi-Fi, like when we came on for rehearsal and my Wi-Fi wasn't working, oh my
Yeah.
gosh, what was I going to do? I didn't have a plan for that one, but
Now
fortunately,
you do.
um, but we do want to think about how quickly can we pivot to our hotspot on our phone, or how quickly can we actually make our phone call to a patient if we're like, do we have their numbers at our fingertips?
Right.
If the Wi-Fi goes down, have we lost that too? We want to try and kind of keep up with all of that if we're pivoting to everything online.
I always have the client's phone number really readily available, not just because if the audio is problematic on the video call, I'm just going to call them on the phone and supplement the call in that way, but because also if there's an emergency, that's the first thing I'm going to do is call them on the phone. So I always like to make sure that's somewhere, on a tab somewhere that I could get to pretty easily. And as you say, I make sure that my personal hotspot is working on my mobile device, which many of us have on our mobile phones or our iPads if we pay for a data plan. Again, not the Wi-Fi, but the data plan that comes with that device. Oftentimes, there will be a free service that allows a personal hotspot as an alternative internet supplier. It can be expensive, so we always want to check with our carriers. We don't want a super big bill at the end of the month, but in a pinch, I know it has saved me before when Wi-Fi has gone out in my neighborhood.
Yeah,
You
we've
mentioned,
got a lot
Margot.
of demands going for Wi-Fi.
Yes, lots of demands. I mean, you mentioned something that I thought was so important, and that is hands. The behavioral observation, how we can communicate rapport and how we can, make sure that we are showing up in a way that is communicative. I think so too. When I think about meeting clients online, I no longer make the same assumptions. I think I'm working a little harder in this way too. If someone met me in a session and they were looking down or they were looking off to the side in my office, I would be wondering about that. I would wonder if they were comfortable. I would wonder if they were avoiding something. I wonder if they wanted to be there. I'd have a lot of questions, and I'd be thinking about how to broach that in a way that felt kind, but also direct. Simultaneously, if they're doing that on a video call, those are all possible reasons that could be happening. They could also be checking their phone. I could keep catching them sneaking off to another tab and answering an email that they've been really worried about for work, or checking on a nanny cam somewhere in their house to see if their children are burning down their home. I no longer make assumptions regarding that behavioral data, and I'm having to ask more questions. I'm also getting to see where people live. I'm getting to meet their cats. There's more data that I'm getting, but I do think that, it goes in both directions, and as much as we cannot assume that we always know what the patient is responding to, just as I'm not going to see them picking a cuticle, tapping a foot, those small psychomotor agitations, so too, I'm not going to see the stimuli that they're responding to in their environment.
Well, and you raise a good point with gaze of, patients, and oftentimes folks do have some sophisticated video equipment at home. A lot of folks who, are finding this more handy. They have an office, they're already kind of set in that mode, but their video feed of me in the session is over here on their big monitor, and they're choosing to look at me. But by doing that, they're not,
Right.
looking at the device where the camera is located. So, I mean, these are just helpful things to talk about, and, be able to kind of establish, what is going on within that session.
And we learned them by making mistakes, so we're here to share them with others.
Totally. But,
I think, Margaret, when we were talking about doing these calls, one of the themes you and I talked about was everything's moving so quickly. We've seen more changes in the past, months than we have in some years, actually, in some areas. And I know we talked about kind of summarizing what are some of the areas where we've seen the most change. I know we hit a little bit on some of the regulatory changes regarding video conferencing platforms that we're permitted to use, a relaxation of some of the HIPAA requirements around email and themes like that. I wondered, I know your specialty is, regulation, and a theme I talk to you a lot about is interjurisdictional practice. I'm curious, what do you have to say about the changes that are happening in these areas?
Well, we certainly had a lot of changes in federal guidelines, but one of the things that we try to teach a lot about is that just because the federal guidelines change related to practice does not mean that your local jurisdiction has changed, or your neighboring jurisdictions. So ASPPB has a fantastic link on their site. They have a lot of updates in terms of both the psychology laws, but they also link over to a website that connects you to all the different jurisdictions and the executive orders that are occurring or that have been posted in all those jurisdictions. And that's super helpful to find for some of your neighboring jurisdictions or places where you may have patients that are stuck in quarantine that aren't able to travel back. So finding out what laws have been, I guess, relaxed, I'll say it that way, in terms of psychology and telepractice is real key. And so that is a site that's constantly updated. It's now I think it's CSG. We have a link on the ASPPB website for it, but they're now having a second page because they had all the first initial executive orders. Those are all going to expire at some point. They're only there for a short time. And so now they have another page that is helpful to look for what's expired or what's extended and some of those changes. Because as this plays out, like we've talked about, there's the initial changes and then there's the unraveling of that. And we want to pay attention on both those sides because every state is doing things a bit differently. And there is no federal kind of everybody doing the same thing with this.
And not only just on those, jurisdictional boundaries issues, practicing from one state to another, but I know we've seen a lot of change also in the regulation governing reimbursement. So here in Washington, we already had legislation that required insurance to cover telehealth. And I know that that has been emerging in many other states. But just recently, we had an order that now requires parity, meaning that telehealth appointments are paid at the same rates, as in-person appointments, which is a big deal, to protecting the incomes and the businesses of psychologists.
Well, and I'm glad you mentioned that because I also wanted to kind of touch upon this idea of a lot of psychologists who are interested in helping out with some of the frontline workers and offering services pro bono. And, while that is, I think, a very kind and heartfelt extension of trying to do something and contribute and help our communities, it is important to remember that we still have to consider those pro bono services the exact same way and do everything the exact same way we would for any patient coming into our office, whether virtually or otherwise, and make sure that we're getting the consent documents and all of those things. Just because there wouldn't be a payment for the service does not, reduce our liabilities or paperwork in those cases.
That's a great point. And it's a nice transition to our sort of final section, talking a little bit about those other, conventions of good psychological practice. Because, as we referenced earlier in our talk, themes like informed consent, themes like emergency plans, these are things that we really want to have in our telehealth appointments, and acknowledging it can be difficult. It can be difficult to get that physical document. So again, going through it verbally is an option. And I always like to mention the trust has some great templates.
Absolutely.
They have great templates for informed consent generally, and then they have an informed consent for telehealth services on their website. And it's a really nice resource. Embedded in that template is discussion of emergency planning, which I appreciate. I always like to mention just what are the components, I think, of a good telehealth consent. What are the themes that I'd want to be sure we're talking to clients about? The risks versus the benefits. Of course, the risks, anytime we put information on the internet, there is a clever 12-year-old with skills better than mine, who can find this information. There's more risk is the reality. We are imposing additional risks. But I think in this circumstance where the benefits of public health, of protecting our health, the health of our clients, is pretty significant. My own analysis is that those benefits outweigh that risk, but it is an individual choice. We want to think about technology disruptions, and we want that in our informed consent. And I actually put it in my emergency plan as well, because some emergencies may not be a clinical emergency or a medical emergency, but if my call suddenly goes black, I'm going to need to be thinking about what am I doing next? So I communicate with my clients if it's a video conferencing appointment, that I will be calling them over the telephone. If it's a telephone appointment, if they have an alternate number, I'm calling it, or potentially I'm sending them a secure message. But thinking through what we're going to do if the technology fails, and additionally, who's going to be financially responsible? That's a tricky one. Yeah. So I like to have that in my informed consent document. And it's very hard to know. It's like if the client came on and said, gosh, I forgot to pay the internet bill and there's no internet today. Sorry, I'm out of internet. That would be a circumstance where it would feel more clear, like, well, this is on your end. But I think the practical reality is we often just don't know. I may have 3 video calls that go great, and then my 4th video call of the day is not so great. I may assume that it's on their end because I had 3 prior calls that went very well and were stable. But the practical reality is I don't really know. I mean, I don't have some magic way of knowing this. I'll tell you, people ask what my policy is, and I usually say that my own policy is that if it is obvious it's on their side, I do regard them as financially responsible. Either way, frankly, even if it's obvious or if it's not obvious, I'm going to offer them the opportunity to reschedule at no charge. So if I can find them and fit them into my schedule that week, I try to find them a spot. In a telehealth context, I have to be cautious not to do it too many times, because I will say I've had some folks cancel, reschedule, and it starts to not be great. So, thinking about that issue soup to nuts, about, who's going to be financially responsible, how are we going to handle, if it's a technology disruption that's, causing the cancellation of the appointment. Thinking about emergencies, I'm always going to have that in my informed consent document, and I'm always going to have a separate emergency plan in my documentation that articulates where the client is, their physical address, and what I would do in case of emergency. Usually I'm calling emergency services to come help them. In the context of coronavirus, it's different because I think our threshold for going to the emergency room is different. I mean, if it's a true clinical emergency and I have imminent concerns about their safety, that's still where I'm sending them. And I will share, I was reading this weekend, and this aligns with some of my ER doctor friends, that fewer people are going to emergency rooms. So in some ways it's kind of ghost towns right now. In some places, of course, some places are overwhelmed with coronavirus clients. I think it really just depends on the community we're in. So if I'm in a community that is just overwhelmed, and that I know that that's a big risk to them, I'm going to think about that a little differently than if I'm in a community that, there are very few cases. They're not, this is an underutilized ER. So I wish I could give like a single level of guidance, but I think we're thinking these things through in our emergency planning. I think through how we're going to,
right? I mean, if you have a patient that you're concerned about and you might be thinking you need that emergency plan to just know what's happening in your community and if they're taking psychiatric patients. So
absolutely, that's a great point, and we figure that out in advance. I'm noting the time, and I'll just mention in my informed consent document, I'm also going to figure out how we're doing payment. Again, it doesn't need to be high tech. They could send me a check, or alternatively, we may have a way through my electronic medical record. HIPAA allows us to use diverse payment systems. And I'm helping to benchmark boundaries. Again, helping folks realize this is a medical appointment. I want them not in their PJs in their bed, but sitting in a private, secure space with nobody walking through the background where they can't be overheard.
Well, I think those are some awesome ideas to really, take home and think through in how we're practicing, and just kind of as we're pivoting to our home office settings, how all of that plays out with our new coworkers and our new schedules and our neighbor's dog in the backyard.
Our new coworker, our children.
Totally. You know, there's so many other aspects to what we're having to incorporate our practices into, and our patients are going through that very same experience. And I love how you talked about just, you know, these are things we have to think about and we want to include in our informed consent and our planning, but it's so easy to be transparent and start our conversations with our clients in our video conferencing sessions, and making sure that we're documenting where they are, or at least where they say they are, including state, by the way, because that will become relevant to future conversations as we're kind of unraveling some of these executive orders and changes moving forward. So, Sarah, this has been so fantastic of a time spent together chatting. I hope others have found this as enlightening and helpful as it has been for me to be having these conversations with you. As we promised, we have a slide that does have our resources that we mentioned on it, and that'll appear in the materials that I think folks can find along in their CE where you where you link into the CE following this. And kind of on that note, we want to make sure that you have the link for the continuing education credit. So in order to receive your certificate for this or participating in the webinar, there is a link that should be appearing in the chat box at this time. You can copy that link and then click on that to go over to take the telehealth exam. Once you finish that, you'll be able to receive your certificate. And this will also, I think, be posted as well in the materials. So again, the helpful resource information, if you want more information from the Trust, they have some fabulous resources in your member profile. If you would like to submit more questions, I've seen a few questions coming in through the Q&As, and you can email them to us at telehealthcommunity@trustinsurance.com, and we'll be pulling all of those together and moving forward with our next telehealth community chat.
Yes, and just a reminder, this Thursday, which I believe is the 30th at 5 p.m. Eastern, will be another risk manager roundtable chat. And then Margot, you and I will be back in 2 weeks to talk more telehealth. And I just want to thank you, Margot, for being here. I always love talking to you. I love talking about telehealth with you. And thank you to the folks who joined us today. And a big thank you to Dr. Martin and her wonderful team at the Trust for having us.
Thanks, everybody. We've really enjoyed our time together, and I look forward to the call with the risk managers and then coming back and chatting again.